Okay. Bismillah ar-Rahman ar-Rahim. Can you hear me, bro?
Yes, we hear you and see you.
طيب. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى صحبه أجمعين. It's really my honor to share this webinar today. And I think we are talking about a very exciting medication that's gonna have a big impact on our patients. So first of all, I'd like to thank the colleague, Mr. Hanouf Al-Harbi from Jalad for arranging this great activity, and also the team behind the scene for doing the logistics and also the engagement of the attendees. And it's really my great honor to share this session with the Prof. Ahmed Badib. Prof. Ahmed Badib is my senior oncologist, and has been my mentor before. He's a well-known professor of internal medicine and medical oncology on the King Khalid Hospital in Najran, and he's one of the people who really reshaped the medical oncology practice in the southern area. So we're quite honored, it's my honor myself to have him with me here today. So for the logistics itself, we are going to be starting in in presentation, where I'll be presenting a baseline, characteristics about the triple negative breast cancer, and also the new medication. This is the sacituzumab govitecan. I'll be presenting a mechanism of action, and then we'll leave the clinical data for Prof. Ahmed, and then later on, inshallah, we'll have the discussion after we finish the presentation. So I'll be sharing the slides from my side, if it's okay with the team. Okay, so is my slides clear for you?
Yes, we can see it.
Perfect.
And we hear you.
Oh. Okay, perfect. So as we said, why we choose this triple negative breast cancer. So this is it's a major role because we know it's a challenge. So that's now, since we have the SJ has started. So SJ, just I'm going to be mentioning that as an abbreviation for the sacituzumab govitecan for the remaining part of the presentation. So we know that this is a major challenge that we face all the time in our clinical practice. So this is the main reason why it's throwing a very big impact right now, and a lot of attention is going to this medication. So this is the general disclaimer, as this lecture is sponsored by Jalad. So we are just going to be going quickly about what's the burden of disease. So we know quite well that the triple negative breast cancer, it's a major issue, and it's a big challenge in our practice. Why? We know that breast cancer alone, it has 2.3 million cases worldwide, and from these ones, 685 patients would die. So this is a huge number. And if we take it in percentage wise, so we know that the 25, almost a quarter of the cases in in female patients, it's affecting to be breast cancer, which they that's each 4 cases diagnosed are related to breast cancer in female. And then unfortunately, the other side, that's each 6 cases, it died because of the breast cancer. So this is a big important thing, same as we see internationally compared to Saudi? The answer is completely yes. And even the last cancer registry that we have in 2020 that has been published by the Saudi Cancer Registry, that breast cancer now is 27%. So it's slightly higher than the general world data. So this is more common. And I guess we're seeing more and more cases, and even the triple negative now is increasing in our country. Okay, so the triple negative part, this is where the focus of our presentation today. So we know that triple negative is one of the subtypes of the breast cancer right now, and it's taking as I said, it's important because there's a lot of advances happening on that, and it's almost constituting 15 to 20% depending on the age and the present family history and mutation. But in general, if you take 100 patients, almost 20% of them would be a triple negative right now. And then we talk about the breast cancer now, it has been subclassified, and initially it was hormonal and HER2 and triple negative, but now we know that we have the luminal A, we have the luminal B, and even the triple negative we're going to see in the next slide. That's the characteristics will be changing in the that. So the hallmark of the triple negative breast cancer, depending on the behavior, it's a high degree of disease heterogeneity. So that's why we see in these patients mixed responses. We see like, abnormal response sometime, and then the aggressive clinical behavior, and unfortunately the poor prognosis are the the painful part of the triple negative, why we are worried about the patient, and we try to find alternative, because we know that being a triple negative alone, this is like, it has a higher tendency for death, and also like, for developing a significant morbidity of that disease. This is would be, in my opinion, like, this is would be the most interesting slide in my presentation today. So you can see here clearly that the TNBC, why it's heterogeneous, because like, we can subdivide the TNBC based on like, we know that the triple negative, there's a certain entity of triple negative, they have a low proliferation, which we don't see them early. But like, the usual one, they come with the high Ki67. This is the high proliferation TNBC. And they can, like, in the classical pathway, they have been talking, is it like, related to the tumor infiltrating lymphocyte or androgen receptor expression? And then if we start to see like, more gene and then more molecular, because this is where the error right now. So we know that triple negative, they have the basal-like disease, okay, and they have like the non-basal-like disease, and the prognosis of these two different completely. And in the basal-like, there's subtypes right now where some diseases, they respond quite well to immunomodulation, and this is the idea where like, to have these patients. And then we have like, the basal-like that had immune suppression. So this is like, would have a different challenge in the way that we treat it. Unfortunately, if there's any way how we can predict that with a CP score, as has been like, prescribed in the first line treatment, this is like, a little bit more a rough way how we can assess the immunogenicity of this tumor, but still like, it's not that 100%. And then we come to the molecular part where I believe like, right now, triple negative, it's a molecular disease, because we can depend like, in the high proliferation in these patients, where usually we discuss about the aggressive neoadjuvant chemotherapy. Then we have like, the immunogenic part where we know like, that immunotherapy now has been getting to be a standard of care in these patients with advanced, and even like, in the neoadjuvant setting. And then brokenness, or like, the changes in these patients, we know like, we have a consistent data right now about the benefit of the use of PARP inhibitor in these patients. So we need to identify that. And now the new way of looking to the triple negative for the androgen receptor expression, and is that like, a fruitful way how we can test it. So still it's in a clinical trial right now. So we see like, here the two different things. If we compare triple negative by non-triple negative in this like, small sketch here, we can see clearly here that triple negative is higher. Patients when they have a recurrence, they unfortunately have a higher chance of brain metastases, they have higher chance of lung metastases, and like, the bone metastasis, which is like, we say a favorable patients with having like, the luminal A and luminal B, we usually like, we see they have bone rather than like, developing a visceral metastasis. So this is one of the reasons why triple negative breast cancer, they have a high mortality. If we look to the graph itself, like, we see that the tendency that those patients, they will start to develop metastases, and some of them like, they will need sometimes like, a longer time. So it doesn't mean that you pass the first or a second year, still late recurrences unfortunately happen in these patients. This is why it's still, we see rare patients who present like, 2 to 3 years or 2.6 years, that the median age for recurrence. We see these patients also with the triple negative breast cancer. So is that like, every patient? We see some patients immediately once they do the surgery, they develop the recurrence, but like, that's the average kind of like, age for like, for recurrence to happen. Is there any different treatment that we can do? I believe now the involvement of immunotherapy in the neoadjuvant setting, that will maybe change the kind of like, the paradigm for recurrence, but that's still, it's too early to judge right now. And this is like, when we compare different types. So if you see the prognosis, the risk of mortality in patients with having different stage based on the subtype of the breast cancer. So you see like, the mortality, the luminal A, which is kind of like, the most benign of the breast cancers that we have. And then we see clearly here that the luminal B, they have like, a higher, like, 3 times, 2 times. And then it comes to the triple negative, we start to see the number jump above 4, which tell us like, unfortunately, that those patients, they have the worst kind of like, mortality. And then if you see here the graph, we see like, unfortunately, that the lower, like, the bottom of the each of like, lines is the triple negative. We see here like, the survival is not the greatest, unfortunately. When we go to see here again, like, on bars, we see that the triple negative has the worst survival, which unfortunately make these patients, they die because of disease. And this is kind of like, the most common, type of breast cancer that has the mortality. So why TNBC is different in a clinical behavior and poor prognosis? So we know that the TNBC is not as simple as it looks like, only being ER, PR, HER2 overexpression negative. But these patients, they would have a germline BRCA status has been changed, so leading to instability, and that's will be reflected later on the MSI. So a lot of patients, they have MSI instability, so that's why maybe they're responsive to immunogenicity. The PDL expression, that's another important, and we know that patient who overexpress the CBS more than 10, they have a better survival. Even they are more than 20, that's even better survival. The TMB, which we know it has been established initially for lung cancer for the benefit of the dual immunotherapy. We know that triple negative, they have also that high TMB, which might be another tool how we can have a targeted treatment for such population. Now we're moving after we talked about the burden of the disease, so we move about how the SG work. And I'd like to maybe to pass a little bit fast, as we have 7 minutes in our for my presentation remaining. So SG, it's a medication of one of the classes of ADC, which is antibody drug conjugate. So this is simply what it is. And why this type of ADC it works? Because there is a receptor called a TROP2, and this is highly expressed in solid tumor. So now we see SG in breast, but there's already data has come in your bladder, in cervical carcinoma. So it might be just a medication that can be used in each type of the solid tumor later on. And we believe because of that expression, will be one important target that for this medication to work. So if you see that majority of the patients here, even hematological malignancy now, they start to have expression of the of the TROP2. So you'd expect later on we'll have a different indication in this population. So how much the expression would be in these patients? So 88% of population, they would have by immunohistochemistry, they have a higher expression of the TROP2. So if we're talking about that 88% of population of the triple negative, they have that expression. This is it make it easy that we can treat majority of the treatment of the patients without a pre-specification about the presence of the TROP2 expression. Here we see clearly the correlation between the TROP2 and the overall survival, and we see here that the survival were it's looking for the HR the hazard ratio of 0.9. So majority of patients has a poor overall survival in these population. Moving toward the molecular part of that, so we see clearly here that the molecular part, we can see the as general ADC. So you should have an antibody that has a fixed antibody FC part, and then we have a linker between the antibody and the treatment, which is the active part, or the active chemotherapeutic part, which is the SN38, and then that's the linker. So it's simply that the antibody is highly specific for this epithelial receptor of the TROP2, and then once it join, they will be activated hydrolysis, and then later on. So we see that the sequence, it goes once the antibody start to bind, then there will be internalization, and then once it moves inside the cell, the intracellular trafficking, then we have the lysosome will do the work for breaking the linker, and then will start the cytotoxicity effect within the cell for the SN38. Then we know that later on there will be a release of that 38, SN38 in the circulation, leading to some toxicity of the treatment that I believe we're going to be discussing later on. We see here some of the pharmaco dynamic of this treatment, that the peak of this of the uptake of this monoclonal antibody, it's happening quick, and the release of the treatment of the SNE in the the SN38 in the blood will be within 3 days. So that's why we don't see that significant prolonged toxicity. And the free amount of the in 38 is very small, limiting the toxicity of such a treatment. And we know, like, these patients, sometimes they have a high burden of disease. So we need to make sure whatever treatment we're using, it has a lower side effect profile. And this is one of the attractive part about the SG that we have. So where we're from algorithm right now. So we know that we have these patients who come with the metastatic TNBC. And right now, as we said earlier, it's a molecular treatment rather than to be assembled triple negative treatment. And that's the ESMO guideline. So they divide this as the BDL positive patients where immunotherapy come taking a priority here. And then we come to have patients who had the germline mutation, where we start to talk about the PARP inhibitors in these populations as a first line. And then the PDL negative patient, usually depending on the burden of the disease, we decide what protocol, either a single agent versus a doublet. However, the second line right now, because of data that Prof. Ahmed will be discussing later on, we're going to have Sismab has been approved to be the second line. And then in further line, depending on the HER2 expression, because now we have this new entity, which is the HER2 low, well, whether they're going to be TDX or other type of chemotherapy, including Rivlin, capecitabine, or whatever, we say chemotherapy of the, physician choice. So this is not already has been updated in the ESMO guidelines. And we see in the NCC guidelines right now, we come to talk about the Sismab has been there as a regimen, as it's giving a category 1 and a preferred. So it's adopted by the biggest two bodies that we have, NCC guideline and also the ESMO treatment. So just looking to that clearly right now, this is what depends on the treatment. And again, we said depending on the PDL expression, the mutation of the BRCA, and the burden of disease, the usual algorithm for the treatment that goes. So at this time, I believe I will stop right now here, and I'll hand the mic to Prof. Ahmed to discuss about the ASCENT trial, and also after that the case presentation. As we agreed earlier, we're going to leave the cases later on. So the mic is yours, Prof.
Thank you very much. Thank you. Thank you very much, Dr. Shadi, for the excellent, comprehensive presentation. You covered all the aspects of triple negative and even the treatment and the mechanism of action. It was very impressive. As usual, Dr. Shadi is, mashallah, professor in King Abdulaziz University, and he's, one of the pillars and corners of oncology in the kingdom. Thank you, Dr. Shadi, again.
Thank you.
Allah Hadak. Now we'll continue the journey by talking about the, clinical part and the clinical study for this molecular drug, and I will share my slides. Yes. So there is still in triple negative, metastatic triple negative breast cancer unmet need, and the role of SASI is coming, and it to a certain limit covers this unmet need in the treatment. This is my disclaimer, and the agenda of my talk, I will try to cover the ASCENT phase 3 trial, and then we'll talk about the side effect of the SG, and we'll end up with case presentation. ASCENT trial is phase 3 trial, and it tried to compare the new drug SG, as we agreed to abbreviate it, with the treatment physician choice, so with chemotherapy. So they were trying to compare the newcomer with what we have in our hands regarding the standard of care chemotherapy in patient with previously treated with metastatic triple negative breast cancer. This is the design of the trial. It is, as we said, phase 3, and it was confirmatory study for the previous trials, and dealing with refractory, challenging, of course, refractory relapsed metastatic triple negative breast cancer. Now, which patient they recruited? They recruited patient with metastasis who exposed to 2 or more chemotherapies for the advanced disease, and also they allowed patient with stable brain metastasis, which are very challenging part of the cohort of patient. Now they divide them in as 1-to-1 measure fashion, and it was 2 arms, SG versus the treatment, the standard treatment, which we have the chemotherapy. So they recruited all the treatment options that chosen by the physicians, For SG, they gave it as 10 milligram per kg IV, day 1 and day 8, every 21 days. So this is the protocol of the SASI, which is 10 milligram per kg IV, day 1 and day 8. They are giving it every 21 days, and they continue the treatment until progression or unacceptable toxicity. Now, and this is the usual way of dealing with breast cancer, metastatic breast cancer. We don't stop the treatment unless if there is progression or unacceptable toxicity. Now, what were the endpoints? The primary one was progression-free survival, while the secondary one, the progression-free survival for the full population, that means intention to treat population, or the overall survival, response rate, duration of response, and time free interval, and quality of life. So they stratified the patient based on the previous or prior chemotherapies they received, 2 or 3 or more than 3, and also based on the geographic region, North America, Europe, and also to the brain metastasis present or not. Now, this is the demographic features and patient characteristic of patient with the in this study, and excluding the in this table the brain metastasis people, and we can see that the two arms are almost comparable. We have regarding they included almost all the races, despite that the predominant one, the white, and but other races are there. And also the performance tests, as usual for the clinical trials, we recruit 0 to 1, and BRCA status with either positive or negative are there. And also they stratify based on the initial presentation. Because, you know, many patients, they may start as hormone positive, then the disease transform during or at the time of metastasis. So most of the patients, they were triple negative at the initial diagnosis. Then they also included one feature, which is the number of lines of treatment. They accepted up to 17 drug used, and which some patients, they were heavily pretreated, but the range or the average was in most of the cases 4 lines of treatment. And then they also allowed those patients who received PARP inhibitors, and they were almost 7% of the cases, and a quarter of the cohort, they received immune therapy before this treatment. This cohort also including varieties of the metastasis, lung only, liver, and bone. And these are the results of the study. They found that the primary endpoint were met in very impressive way. So look to the left side of the presentation of this. You can see here that the primary endpoint, which is the progression-free survival, was there and met. We can see 5.6 months progression duration of the median progression-free survival in comparison with chemotherapy 1.7. And look to the hazard ratio, it was very impressive, 0.41 with significant p-value less than 0.001. Look to the separation of the curve. Clearly, this curve showing the superiority of the newcomer over the standard of care or the chemotherapy. Now, when it comes, look to the right side of the slide, you can see of the overall survival. And we can see clearly that we have 12 months median overall survival in comparison with 6 months. So double duration of overall survival by using of the SASI. And the hazard ratio also maintained 0.48 with significant p-value less than 0.001. So the primary endpoint was met. And this analysis was in those patients with without brain metastasis. Now they also look to the response rate and look to the curve here, we can see clearly the waterfall plot that we have in the upper side. We can see the effect of the depth of the response for the SASI in comparison with the chemotherapy. It was almost 35% overall response rate for the SASI in comparison with chemotherapy, only 5%. And the other important point is the duration of the response. We can see that we have 6 months versus 3.6 months for the chemotherapy. So we have we doubled the overall response rate and also the duration of the response. Now, when we consider the subgroup analysis regarding the progression-free survival by subgroup, we can see that the superiority of the SASI is there regardless of the age and race, and also the prior therapies, 2 to 3 versus more than 3 lines of treatment. Also the racial types or categories, and also the prior use of immunotherapy, the presence or absence of liver metastasis, and if the patient was initially pure triple negative or transformed from another category to triple negative status. So all the subgroups were benefited from the use of the SASI. Now, when they considered the overall population by intention to treat analysis for the progression-free survival, overall survival, in the previous analysis, they excluded the brain metastasis people. Now, this is for the intention to treat for all the population. We can see the benefit was reproduced and it is there. We can see that SASI again showed almost 5 months progression-free survival in comparison with chemotherapy 1.7, and the hazard ratio also maintained nicely. It was 0.43, and the p-value is there also. And when it comes to on the right side of the screen, you can see the separation of the curve also regarding the overall survival, and the median overall survival was double the chemotherapy, and the hazard ratio was almost 0.51 with significant p-value. Now, then they considered or separate those people who received 2 lines of treatment, and they noted that the response was impressive in this cohort group, and we can see that almost the progression-free survival almost 6 months versus 1.5 months for the SASI versus chemotherapy. And based on these data, when the FDA approval or the approval of the drug allowed 2 or more systemic therapies to be in order, they opened the way for the treatment that we can accept 2 lines of treatment, but at least one of them should be in the metastatic setting. So we can use it now in the second line after using of only 1 line of treatment. Now, the overall survival is again is there and maintained in this subgroup of the patient. Now, they subdivide the subtypes and one by one of the major chemotherapeutic agents, and they compared SASI with the individual chemotherapeutic agents in the other arm. So for now, look to the green light. The green light, this is the SASI, and the uppermost, which is in the left side, the progression-free survival. The right side, we have the overall survival. Look to the superiority of the uppermost green line, which is the SASI, in comparison with the 4 major drugs: eribulin, vinorelbine, capecitabine, and gemcitabine. We can see that SASI showed almost PFS, progression-free survival, of almost 6 months in comparison to the others, which range between 1.6 months to 2.7 months in the chemotherapeutic age part. Thereafter, they also a little bit went to the basic oncology and pharmacology, and they looked to the effect of the TROP2 expression on the response to the treatment. And on the progression-free survival, they compared those patients with high expression of TROP2 biomarker versus the medium level versus the low score of the TROP2. And as Dr. Shadi said, that we have almost 88% expression of the TROP2 in the breast cancer patient, and we have the clinical benefit in terms of the progression-free survival is there, whatever or irrespective of the level of the TROP2 expression in these cases. We can see that we have 7 months in those patients with the high TROP2 level. We have almost 5.6 months for the medium and 3 months for those with the low expression. The benefit is there, but when we have the higher the level, the better is the response. Now, the health-related quality of life, usually we consider it as very important part when we deal with patients with metastatic cancer, because the purpose of the treatment is mainly palliative. So we have to respect the patient quality of life. And when we reviewed the 4 domains of the health-related quality of life, we can see that SASI arm showed clinically meaningful and greater improvement in all aspects: the global health status, physical functioning, role functioning, fatigue, and pain, all in favor of the SG. We'll go now to the side effect, and we can see that this is the usual scenario for those antibody drug conjugate drugs. Usually in these drugs, we have 2 main side effects: neutropenia and diarrhea. And for us as medical oncologists, we are concerned mainly regarding the grade 3 and 4 toxicities. We can see that yes, the toxicity is there, I mean the side effect, but the good thing that it did not lead to febrile neutropenia, significant febrile neutropenia that clinically significant. Now, when we have 50% neutropenia in the SASI in comparison with 33%, we have diarrhea 10% versus 1% in the chemotherapy, and we have leukopenia. But when it comes to the febrile neutropenia, it is almost 6%, despite that we have 50% neutropenia. The incidence of the febrile neutropenia only 6%, and it is 2% in the chemotherapy arm. And almost 50% of the patient received SASI, they received Neupogen or GCSF, and almost quarter of the patient who received chemo, they have it. Now, dose reduction due to side effect was similar between the 2 arms, and this is the most important point. So in addition to that, there is no severe cardiovascular toxicity and no more than grade 2 or neuropathy, and no more than grade 3 interstitial lung disease for the SASI arm. And there is no treatment-related deaths with SASI arm. There is one in the whole study. We have 1 treatment-related death. It was neutropenic sepsis. It is in the chemotherapy arm. Now, the treatment exposure, we can see that in the SASI arm that almost most of the patient, they continue in the average, they continued on the treatment for 4.4 months, while for the chemotherapy arm, they did not continue more than 1.6 months in the range. Now, regarding the elderly age group, we can see that we have the same almost side effect without any safety alarm or alerts in comparison with the overall population. This is the summary of the slide. And when it comes to the post-hoc analysis regarding the median time to onset of the side effect, we can see almost the time to the onset or to the start of appearance of the side effect in the SASI arm is comparable with the chemotherapy arm, except for the anemia, which a little bit maybe a little bit more prolonged. Now, for the neutropenia, now, if we, as I mentioned before, did the neutropenia lead to discontinuation of the treatment? We can see that the discontinuation rate in SASI, it was 0 in comparison with 1% in the chemotherapy arm. And what about the effect of diarrhea on the treatment discontinuation? It is almost led to 0 discontinuation of the treatment in comparison with the chemotherapy arm. We'll end our talk with the dosing and administration. The dose of the drug and the administration. The most important that we have to be careful that we should not substitute SASI for, or we cannot use other drugs containing irinotecan or it is active metabolite. We know that this is the prodrug of the irinotecan, so it is they are almost the same group. And also we have to be careful about the dose of SASI that should be 10 milligram per kg given as infusion, day 1, day 8 for 21 days cycle. Now, and we continue, as we said, until a disease progression or unacceptable toxicity, and we should not cross the dose of 10 milligram per kg and should be given only as infusion. We should not give it as push or bolus. So the recommended dose is clearly 10 milligram per kg once weekly, day 1 and day 8 for 21 treatment cycles, continued until disease progression or unacceptable toxicity. Now, for the first infusion, we have to give it over 3 hours, and we have to observe the patient during the infusion and for at least 30 minutes following the initial dose for any signs of infusion-related reaction. And in the subsequent infusions, if the patient safely received the treatment, we can give it in the next cycles over 1 to 2 hours. And we have again to observe the patient during the infusion and for at least 30 minutes after the infusion. So this is important to remember. And for the pre-medication, we have to give pre-medication with antipyretics and H1 and H2 blockers prior to the infusion, and steroid also may be used for the patient who had prior infusion reaction. For the chemo-induced nausea and vomiting, we have to use 2 or 3 drug combination. Usually we use dexamethasone with either ondansetron or NK receptor inhibitors like abripitant, and we have to individualize case by case. So for pre-medication, for prevention of infusion reaction, and chemo-induced nausea vomiting, we have to use clearly the pre-medication mentioned above. Now, for the dose modification, we have, of course, to closely monitor the patient for hypersensitivity, as we mentioned, and we have to observe the patient 30 minutes, not only during infusion, but also 30 minutes after completion of each infusion. And we have, if the patient develops some sort of reaction, we have to slow or interrupt the treatment based on the severity of the reaction. If the patient develops life-threatening infusion, then we have to stop or discontinue the treatment permanently. So closely monitor patient for hypersensitivity and infusion-related reactions during each SASI infusion and for at least 30 minutes after completion of each infusion. Now, for severe neutropenia, we deal with it case by case. So if the patient developed grade 4 neutropenia and it was prolonged more than 7 days, or grade 3 febrile neutropenia, that means the patient developed ANC less than 1,000 with grade 3 neutropenia with fever. So we have to consider dose reduction all. And also, if the patient reached to the time of the scheduled treatment, while still he has grade 3 to 4 neutropenia, that led to delayed the dose by 2 to 3 weeks to reach to the acceptable grade, which is 1 or more, So 1 or less, then we have to reduce the dose by 25% dose reduction, and we have to give GCSF. Now, if repeated, then we have to, if we cannot reach to the goal, we have to reduce the dose at the second time by 50%. And in the third time, if we did not reach to the goal, then we have to discontinue the treatment. And we should not re-escalate the SASI dose after dose reduction for adverse reaction. So we cannot go back to re-escalate the dose. Almost we applied the same principle for the non-hematological toxicity, depend on the grade. If it is grade 4, we have to, at any duration, we have to reduce the dose immediately by 25%. And if we have also grade 3 to 4 nausea or vomiting or diarrhea, we have to consider the same action. And if we have any toxicity grade 3 or 4 continued for more than 2 days, despite optimal treatment, consider dose reduction. And if the patient reached to the time of the next cycle without improvement, and we delayed the chemotherapy or the SASI for 2 or 3 weeks, then we have to consider it as important reaction side effect that necessitate dose reduction by 25% the first time, 50% second time. Then we'll discontinue the treatment if the trials failed. I will end my talk with this. One of my patients, this patient is a 54-year-old BRCA negative lady. She had PD-L1 positive by 22%, and she gave her son also under treatment in our center with the lymphoma. He has Hodgkin lymphoma. And the patient has history of chronic depression. She is under antidepressant. This patient, when we dig deep in her history, she gave history that 2017, she finished 4 cycles of R-CHOP for non-Hodgkin lymphoma, diffuse large B-cell lymphoma. And the history of this patient regarding the breast cancer started November 2021, when she diagnosed as metastatic triple negative breast cancer. It was ER negative, PR negative, HER2 0. And at the time of presentation, she had metastasis to the lung, liver, lymph node, and pericardium. So this case will make it as, interactive discussion, and we need your thought about the options of the treatment for this patient in the first line as category 1 option. So we have this patient. She is, I will repeat, she is 54 years old. She is BRCA negative. She is PD-L1 22%. She's metastatic breast cancer, triple negative with HER2 0. And she's looking for your suggestion regarding the treatment options. We have here on shelf, all the drugs are available. We have trastuzumab deruxtecan, we have systemic chemotherapy, we have pertuzumab plus chemotherapy as an option. We have olaparib, talazoparib as PARP inhibitors. We have SASI as an option. Please vote. Okay, take your time. Yeah, anybody want to give opinion?
I think, Prof, we have everyone now has joined or has voted. So if you want to go ahead.
Yeah. Okay. So yeah, we have it now. We can see the answers that almost 42% they choose it SASI jofetican. We have 33%. They you see the result? You see the result? The poll result? You see it?
Yes, Prof. How we see, 25% they voted for systemic chemo, 8% they systemic for TDX, 33% voted for Pembro plus chemo, and 0% voted for Barb, and 42% they voted for Sassuman.
Yeah. So we have different opinions, and now we'll go to always our reference is the guidelines. Now, most of you you opted to go to SASI as option for this patient. The second group comes the C, Pimpro plus chemo. So we'll see what we have in the guidelines. Now, we are talking here about patient in the first line setting. Our patient is PD-L1 22%. And the guidelines are telling us clearly that any patient with PD-L1 more 10% or more, regardless of the germline mutation, that we have to go to the category 1 option. The category 1 option, the preferred option, is to use Pimpro plus chemotherapy, and this is the treatment of choice. So usually we have to respect the option, and if the patient is PD-L1 negative and also BRCA negative, then we may go to chemotherapy alone. If the patient BRCA positive, the preferred option is to go to either PARP if we have it, or platinum-based therapy. So based on that, the correct answer is C. So we chosen for our patient Pimpro plus chemo based on the guidelines. So the patient started on treatment, and she completed in November 2022 6 cycles of chemotherapy. She received Taxol and carbotaxol. It was given as weekly Taxol with carboplatin and Pimpro. And the patient has multiple dose reduction, multiple times delayed due to low neutrophil count. And thereafter, she achieved almost initially stable disease. And then she started maintenance therapy. Now, the patient came in January 2023 with disease progression. So she has a new left breast mass, and she has right-sided pleural effusion, and also she has a mild to moderate pericardial effusion. So we are dealing with the challenging issue. In addition to, also we noticed that there is she has some sort of unsteady gait, and when we did brain MRI, we found that the patient has tiny left cerebellar focus of abnormal enhancement, very small, very tiny. We drained these images of most of them. They are after drainage of the pleural effusion. We cannot see it, only residual. And we have pleural cytology was positive for malignancy. The tumor marker always normal. And then we have the patient. We are dealing with patient who relapsed after the first line, which you selected Pimpro. And the patient now, she had still acceptable performance status. She's a little bit bothered with this anesthesia due to cerebellar lesion and pleural effusion already drained. This is the X-ray of the patient after drain, and we have the CT scan. We have clear pleural pericardial thickening, the breast mass now, and the axillary node prominent, and the cardiologist said this is mild to moderate pericardial effusion. And this is the brain MRI. We have a tiny cerebellar lesion. Now, what is your option for this patient? She failed the first line, and almost we are stuck with this progression everywhere. And the patient performance almost to what treatments in our hand now? Can we go to trastuzumab deruxtecan, or just give chemotherapy, or we'll try PARP inhibitors, or SASI, or we'll continue Pimpro plus chemo as long as the patient did not, receive it a long time? What do you think? Can we vote, please?
We have 24 attendees, so we expect bigger number to vote.
Yes. Yeah.
Okay.
Okay, so we have
more than
almost
50% voted. If you want to proceed.
Yeah, exactly. So now we have yeah. You see the result. Now we have almost 62%. They voted for SASI in this case, and the others almost negligible. I mean, almost. So we have now again. We'll decide based on the guidelines. Always we can respect the guidelines. So what the guidelines telling us in this regard? The guidelines are clear, and this also presented by Dr. Shadi clearly that if the patient has, in the second line, we have to look. If the patient has, I mean, germline, we have to, BRCA, we have to go to PARP inhibitors, which we don't have it. If the patient has none if the patient has HER2 expression, low expressor, we have to go to strazosumab deruxtecan. This is the drugs used for I mean, HER2 positive patient. While if the patient has none of these, he has category 1 option is to go for sacituzumab govitecan. So the correct answer is SASI as category 1 and the preferred option. So this is the correct answer. So response D was the correct. So this is the usual scenario in such cases. This is the best candidate for use of SASI, and this is category 1, and this is the preferred regimen. So the patient now going to receive this drug as respecting the guidelines. Now, the question by the patient and her family asking, when we are discussing the results and the expected, I mean, survival by using of this drug, based on the ASCENT study, what is the expected median overall survival in months for this patient? Please vote. The options are 7 months, no survival benefit, or 12 months, 11.8. So we have now till now almost how many voted? 9. Yeah. We are waiting for the others to vote. Please give your opinion. Just it is, I mean, trial. Okay, so almost 67% they chosen the first choice, 1A, and we have 22% they considered 12 months. So just I will remind you that this is the figure which we have, which we presented. Now look to the result of the ASCENT trial regarding the progression-free survival and overall survival. On the right side, this is the overall survival. So for those patients, this is the green light for the overall population, and we consider this patient among the overall population because she has brain mets. So this patient, she will gain almost a median overall survival 12 months in comparison with the 6.9 for the chemotherapy. So the expected is 12 months. This is the correct answer. We'll move. Now, the other question coming, what if this patient progressed on SASI? What will do for this patient? We have, please, if we can vote, we have options. Can we revisit Pembro plus chemo? Is it the correct answer? Or we'll do NGS, that means next generation testing, molecular testing, and looking for for any actionable mutation, or we give chemotherapy if we don't have this NGS testing. This is a B. The other option to give PARP inhibitors, C, or to continue SASI after progression, or to use the anti-HER2 drug trastuzumab deruxtecan. Please vote. Start voting, please. Yeah.
Okay, Prof, should we go? I think we have more than 50%.
Yeah, I cannot see the results. Yeah, now it's here. Almost we have 50% selected B. That means they will go for NGS testing or they will give systemic chemo. Still 20% they consider to revisit the immune therapy plus chemo. And okay. So we'll see what in our hands now. Now, for after failure of the first line, second line, now we have the third line and beyond option. Again, it is well described in the guidelines. If we lost the first line and the second line, we have to go for dig deep in any positive biomarker. So we have to consider NGS. Or if we don't have, at least we have to do the NTRK and RET and the other tumor mutation burden. And now looking for any actionable mutation. And if we have it, will be the best option for the patient to tackle such and go behind such mutation. Now, if we are not lucky and the patient and we don't have the test or we did not find any positive actionable mutation, then we have to choose systemic chemotherapy. So the correct answer is B. So we have to go for molecular testing. If we don't have the molecular testing or we don't have actionable mutation, then we give systemic chemotherapy. This is my last slide, and thank you very much.
Well, thank you, Prof, for this very nice case and also the discussion of the study. So as just to recap for what Prof has been mentioning about the guidelines and the amount of the survival advantage, that was what was striking, because we know that this triple negative is one of the challenging diseases, and to see an overall survival of almost 6.9 all the way to 3.8, 11.8. This is an improvement of minimum of 5 months, which is we don't see it with the other clinical trial in very challenging and highly aggressive tumor. So this is what people find it as an option in a disease where we don't have a lot of options, unfortunately, to do. So this was very nice. While we're waiting for other question, Prof, may I just give a quick question? Do you think in other patients who has PARP inhibitors and these other actionable mutations, so now in these patients when we move if they are immunotherapy, we go with immuno plus chemotherapy, and then second line we have the sacituzumab, and then if they don't have anything in your second line is sacituzumab.
Yeah.
In patient who has a PARP inhibitor, if you're using it as a first line, single agent, so do you think your second line will go directly to sacituzumab, or still you might consider some systemic chemo before that?
We have guidelines are very clear in this regard now, and the earlier the use of SASI, the better the results. So This is very important, and this is one important point that we have to consider, because we noticed from the, both Tropicus and Ascent trial that the later they use the drug, the later they use, the worse or the less the response rate. So, and it is clearly mentioned in the guidelines as category 1. Again and again, we have to not, this is not only my opinion, it is not usually when we have clear statement from the guidelines, they put in the second line category 1 and as preferred option SASI. This is not personal opinion. This is the guidelines, and this is compatible with the data which we have, that the earlier the use or the introduction of SASI, the better the results.
So again, this is the main reason why I brought this question. So make sure when you have an active medication, especially it has a very significant overall survival, try to use it early before the patients become very sick, because we know that these triple negative, they're very prone to have brain metastases, or they have aggressive disease, so they will not be able to use these systemic treatment. So if you have a patient with the BRCA mutation, consider BARB and then jump directly to chemo. So to Javitican before you delay.
Yeah, Dr. Shadi, the challenging point also, even now, if we have, I want to share with you and to hear your opinion now. If we have patient with BRCA positive and the second line, we are moving to the second line setting now, and at the same time, the patient has brain metastasis and or high burden disease. Now, the results, the response rate for PARP inhibitors is not satisfactory, especially for those we don't have enough data for patient with, BRCA positive. So my option maybe also, even if I have BRCA positive in the second line setting, but I have brain mets, like in my the scenario which I have, I may opt to use to delay the PARP inhibitors a little bit to get rid of the disease burden, and because we have clear data about the benefit of SASI in the brain mets population and the high burden disease, including the different sites of metastasis. I don't know if you agree about this approach.
Yes. Well, metastatic triple negative who has brain metastasis, this is a very very unlucky patient, because unfortunately usually they have a multiple rather than a single agent. So that's one challenge. The second challenge, even if they have a BRCA mutation, there was no clear subgroup analysis in the patient who had the BARB inhibitor with the brain metastasis itself. So it wouldn't be that logic as what we're seeing with this clean data that we have from the Ascent trial. Okay.
Okay. I have also another question, just in discussion. It is mainly a discussion about your insight, Dr. Shadi, for why SASI win the battle in comparison with chemotherapy. Despite that we are almost using aggressive guns like capecitabine, which is very strong drug, or the others. But at the end of the day, we found very, a strange separation of the curve and almost doubling of the response and PFS overall survival. What is the possible cause of failure of chemotherapy in this in Ascent trial?
Yeah. I think majority of patients who were on the medication, they were on Eribulin, which we know that is not that quite powerful systemic treatment. So I think that's one agent. The second part, I believe it's mainly because as we see, initially with the Kadcyla, when it comes, I believe that all these ADC, they have a very high intracellular concentration of the chemotherapy, which I think it's a main reason why we have a good response. The response rate is very, clear in these patients, and also the survival advantage is there. And being limited free drug in the blood, only less than 2.5% as per the clinical trial. The pharmacodynamic part. These, will limit the side effects that the patient gets with chemotherapy, and I believe that's another reason why patients they have a higher number of cycles while on the sacituzumab compared, to the systemic treatment. So it's multiple factor, but I think this is one of the important part. Why, so if you see, with Kadcyla right now, The only thing that comes to override the Kadcyla is another ADC, so the TDX, which I believe that it's a future of our if we still were using the chemotherapy, we should carry it in a way that patients don't develop a lot of toxicity and try to have a high intracellular concentration.
Yeah, I think I concur with you. Really, it is. I think it is a class effect. It is new drug. We are talking about new way of treatment of triple negative breast cancer. It is not because some talks about the trial itself design and the representation of the response rate in the chemotherapy arm. But my feeling that it is matter of it is a mechanism of action, new mechanism of action, and it is new class of medication that affected the the result in this regard. The other point now for the brain metastasis in this patient, you noted that my patient has tiny lesion in the cerebellum. So really, I stuck it with this patient. What I have to do, very tiny, it is non-specific, and despite that, he has some sort of anesthesia. And when, in your opinion,
in our center, we usually use stereotactic.
Yeah, so you will consider as the brain metastasis, or you will just keep following it up and.
Well, given she had the neurological and she had a diffuse metastasis too, so she had everywhere metastasis, so it's not unsurprising, especially she had already neurological symptom. So I think she should deserve to have a stereotactic. If we're giving whole brain radiation, maybe this is something else we need to worry, because of the side effect of the whole brain. But with the limited stereotactic, we have been seeing patients, they're doing quite well, even after the treatment with the stereotactic. Okay, I think we're going a little bit behind the time. We are already has passed the time that we're allowed, and I see it's too late on Thursday night. So I think we had a very quiet evening, and it has been my honor to share this session and the presentation with Prof. Ahmed Badib. We had a very fruitful, I believe, discussion about the data and also the clinical case that he presented. Thanks for Jalad team, and special thanks to Ms. Al-Hanouf for her arrangement. And I will leave the mic for you, Al-Hanouf. Tfaddali.
All right. Thank you so much, Dr. Shadi, and also Prof. Ahmed. On behalf of Gilead, we are really appreciated, and it was a very fruitful discussion. And let's keep on helping more metastatic triple-negative breast cancer patients.
Thank you very much. Thank you for all.
Thank you all.
Thank you.
Thank you. Okay, have a good week. Have a good night and
Great
good
night.
weekend. Thank you.
Thank you. See you. Bye.